Hi, my name is Osama Naga. We'll continue the Pediatric Board Review series. In this video, we'll explain acid-base disorders. This video is a supplement to the renal disorder chapter explaining the acid-base disorders, and the renal chapter starts from page 371 to page 392 in the Pediatric Board Study Guide. By watching this video, you should be able to know the mechanism for regulating acid-base physiology, differential diagnosis of metabolic acidosis associated with high anion gap, differential diagnosis of normal anion gap metabolic acidosis, pulmonary compensatory changes in metabolic acidosis, and alkalosis. Acid-base disorders. It is very important and critical for any clinician providing care for children to understand the acid-base disorders. This can make a difference in the diagnosis and the management of many cases in pediatrics. The pH is the first thing to look at when you are presented with ABG or arterial blood gas. You want to know if you are dealing with a case of acidemia or alkalemia. So first thing, check the pH. If the pH is more than 7.45, this is a case or a state of alkalemia. If the pH is less than 7.35, you are dealing with a case or a state of acidemia. So what's the difference between acidosis and acidemia? Acidosis is the driving force or the process towards the acidemia. What is the difference between alkalemia and alkalosis? Alkalosis is the process or the disorder driving the pH towards the alkalemia. So alkalemia is the pH, the state of the arterial pH, and acidemia is the state of the arterial pH. So first thing, when you are presented with arterial blood gas, check the pH. If the pH more than 7.45, this is a case of alkalemia. If the pH is less than 7.35, this is a case of acidemia. Second step in checking ABG or arterial blood gas to look at the PCO2. What is the PCO2? Is arterial blood partial pressure of carbon dioxide. If the PCO2 is less than 40, this is respiratory alkalosis. If the PCO2 is more than 40, this is respiratory acidosis. So if the PCO2 is more than 40, acidosis means that the patient is hypoventilating and retaining more CO2. If the PCO2 is less than 40, means that the patient is hyperventilating and washing more CO2 from the lung, and this can cause respiratory alkalosis. So PCO2 less than 40, respiratory alkalosis. More than 40 is respiratory acidosis. The next value is very important to understand on ABG is bicarb. If the bicarb is low, this indicates metabolic acidosis. If the bicarb is high, this indicates metabolic alkalosis. Why I don't put number here? Because it varies between the ages. So the value of the bicarb is different from one age to another. For example, age 1 to 2 years, the normal value between 17 to 25. If you look at 18 years of age, is between 22 and 29. So you can put number, for example, 24 as your guide to remember. If it's less than that, is metabolic acidosis. If it's more than 24, is metabolic alkalosis. But if you want to go by exact number, you need to use a reference for age. In this video, we'll learn the 4 categories or 4 primary acid-base disorders and how to understand them and how to apply them in real life. The first one is respiratory acidosis. It can be acute or chronic, and respiratory alkalosis can be acute or chronic, metabolic acidosis and metabolic alkalosis. So again, we'll learn these 4 disorders in the next few slides. The first category is very important. The most common is metabolic acidosis. Metabolic acidosis is decreasing the pH and decrease bicarb. Decrease pH and decrease bicarb. Metabolic alkalosis is increased pH and increased bicarb. Respiratory acidosis is decreased pH and increased PCO2 or carbon dioxide. Respiratory alkalosis is increased pH and decreased PCO2. We'll understand that in more details in the next few slides. This diagram is to simplify the acid-base disorder. In the cases of alkalosis, it could be metabolic or respiratory. In the cases of metabolic alkalosis, the bicarb will be high. In the cases of respiratory alkalosis, the PCO2 will be low. In the cases of acidosis, if it's metabolic, the bicarb will be low. and in the cases of respiratory acidosis, the PCO2 will be high. Cases of respiratory acidosis or alkalosis is controlled by the PCO2 in the lung. The PCO2. So the PCO2 can be managed by the lung either by hyperventilation or hypoventilation. Hyperventilation will wash more CO2 from the lung and will cause respiratory alkalosis. Hypoventilation will retain CO2 in the lung and will cause respiratory acidosis. This is how the lung manage the cases of respiratory acidosis and respiratory alkalosis. In cases of metabolic acidosis and alkalosis, this how the kidneys manage the bicarb. The kidneys manage the bicarb value by increase or decrease the renal reabsorption of bicarb in the proximal renal tubule, and manage the bicarb also by increase or decrease the renal excretion of hydrogen in the distal renal tubule. So the lung manage the PCO2 and the kidneys manage the bicarb. The kidneys by increasing or decreasing renal reabsorption of bicarb, or increase or decrease renal excretion of the hydrogen, and we'll understand that more in the next few slides. Simple way to determine acid base. First thing, check the pH. If the pH is less than 7.35, this is acidemia, and you need at least one acidosis to find one acidosis in the blood gas. If the pH is more than 7.45, this is alkalemia. So you are dealing with alkalemia, but you need at least one alkalosis to find one alkalosis in the blood gas. And all of this will make sense when we start to practice with the clinical cases. So again, when you are checking ABG, check the pH first. If the pH is less than 7.35, this is acidemia. You want to know this acidemia is because of metabolic acidosis or respiratory acidosis. So the next step is to check the PCO2. The PCO2, if the PCO2 is less than 40, it is metabolic acidosis. If the PCO2 is more than 40, it is respiratory acidosis. Check the pH. If the pH is more than 7.45, it is alkalemia. You want to know if this alkalemia is because of metabolic alkalosis or respiratory alkalosis. So the next step is to check the PCO2. If the PCO2 is more than 40, it is metabolic alkalosis. If the PCO2 is less than 40, it is respiratory alkalosis. Note here, there is a hint for you to remember. If the PCO2 is in the same direction of the pH, like means that the PCO2 is low and the pH is low, this is metabolic. If the PCO2 in the opposite direction means that the PCO2 is high and the pH is low, this is respiratory. That, like in this case, respiratory acidosis. If both of them are low, this is metabolic acidosis. Also, you can see that the same here. If the pH here is high and the PCO2 here is high, this is metabolic alkalosis. So if both of them are high, this is metabolic alkalosis. And if they are in the opposite direction, the pH is high and PCO2 is low, this is respiratory alkalosis. So, and we'll learn that more in the next few slides. Again, check the pH value or the change in the pH and PCO2. If the change in the pH and PCO2 are in the same direction, you are dealing with metabolic. If the change in the pH and PCO2 you are in the opposite direction, you are dealing with respiratory. For example, here, if you have low pH and low PCO2, it is metabolic acidosis. If the high pH and high PCO2, it is metabolic alkalosis. So if it's low and low, it's metabolic acidosis. If it's high and high, it is metabolic alkalosis. If the change in the pH and PCO2 in the opposite direction is respiratory. So if the pH is low and the PCO2 is high, it is respiratory acidosis. If the pH is high and the PCO2 is low, it is respiratory alkalosis. So same direction metabolic, opposite direction respiratory. We will take some different blood gases as example to be able to apply the information we have discussed previously and how to determine the primary acid-base disorder. First thing to check with ABG, the pH. So the pH here is 7.26, which is low. Second thing you check is the PCO2. The PCO2 here is 61, is more than 40, which is elevated. So again, the pH first is 7.26, is less than 7.35. This is a case of acidemia. Then next step to check the PCO2, which is 61, which is more than 40. So this is a case of respiratory acidosis. So again, you have the pH is low, which is acidemia, and the PCO2 is elevated, which is the opposite direction of the pH. So this is a case of respiratory acidosis. Later on, we'll understand the compensation. As you see here, the bicarb is slightly elevated, which is a secondary metabolic alkalosis, which is the body trying to correct the pH to make it a little bit more elevated towards normal. Case number 2. Check the pH first. So the pH here is 7.51 and the PCO2 here is 18, which is low, and the bicarb is 17. So step number 1 to check the pH. The pH is 7.51, which is more than 7.45. This is a case of alkalemia. And the PCO2 here is 18, which is less than 40. So it's in the opposite direction of the pH. So this is respiratory. And the pH here is alkalemia, and the PCO2 is less than 40. This is a case of respiratory alkalosis. So again, the pH is more than 7.45, is 7.51, and the PCO2 is less than 40. And you see here, this is elevated, this is low. So they are in the opposite direction of each other, or the PCO2 is the opposite direction of the pH. This is a case of respiratory alkalosis. If you look at the bicarb here, is slightly low. So this is a secondary metabolic acidosis. The body is trying to correct the alkalosis by bringing the pH a little bit down towards normal value. So number 1, you need to check the primary disorder, and it will have separate cases to learn how to check for compensation. But at least we don't want to miss this opportunity to learn also about compensation. So the first thing to check the pH, second thing to check the PCO2. Never go to the bicarb after the pH. You will miss the primary disorder. So check the pH, then the PCO2. If they are in the opposite direction, you are dealing with respiratory. If the pH is alkalemia, so this is respiratory alkalosis. Case number 3. The ABG here shows pH is 7.51, is elevated, and the PCO2 is 45, more than 40, is elevated. So you have both pH and PCO2 are elevated in the same direction. This is a metabolic case. So the pH is more than 7.45, which is 7.51. So this is a case of alkalemia. Then the next step is to check the PCO2. The PCO2 is more than 40. So both pH and PCO2 are high, so in the same direction. So this is a case of metabolic alkalosis. So the pH is more than 7.45 and the PCO2 is more than 40. Both of them are elevated. This is metabolic alkalosis. So what happened here to the PCO2? Why is elevated? The lung is trying to compensate. The lung is trying to bring the pH down by causing respiratory acidosis. So the patient will be hypoventilating, retaining more CO2 in order to correct the pH down. That's why the PCO2 is high or elevated. The bicarb here is elevated, which is metabolic. So this is a case of metabolic alkalosis with secondary respiratory acidosis. Case number 4. The pH here is 7.15, is low, and the PCO2 is 36, is less than 40, it's low as well. The bicarb is 11, is low as well. So you have the pH is low and the PCO2 is low. This is a metabolic case. So the pH here is 7.15, is less than 7.35. So this is a case of acidemia. Then you check the PCO2, the next step. Never go to the bicarb before. So you check the next step is the PCO2, and the PCO2 here is 36, is less than 40. So both are low. The pH is low and the PCO2 is low. They are in the same direction. This is a metabolic case. So this is a case of metabolic acidosis. Why? The pH is low and the PCO2 is low. Both are low in the same direction. This is metabolic and this is acidemia. So it's a metabolic acidosis. And the bicarb here is low as well, is less than 24. So why the PCO2 is low here? This is a secondary respiratory alkalosis. Why? The lung is trying to compensate. The lung is trying to compensate by washing more CO2 from the lung by hyperventilation trying to elevate the pH towards normal. So this is ametabolic acidosis, or the primary disorder is metabolic acidosis with secondary respiratory alkalosis. We'll start with the compensation, and we'll learn how the body can compensate in different cases of acid-base disorders, trying to correct the pH towards normal. This is a simple table to explain the primary disorder and the compensation. In cases of metabolic acidosis, the body will compensate by hyperventilation, and this will decrease the CO2 and will cause respiratory alkalosis, and this will be the compensation for metabolic acidosis. Metabolic alkalosis, the body will hypoventilate and the respiratory rate will decrease, and this will retain more CO2 in the lung and will cause respiratory acidosis. So respiratory acidosis is the compensation for metabolic alkalosis. In cases of respiratory acidosis, the body or the kidney will compensate by increasing the renal reabsorption of bicarb in the proximal renal tubule, and will increase the renal excretion of the hydrogen in the distal renal tubule. In cases of respiratory alkalosis, the kidney will compensate by decreasing the renal reabsorption of bicarb in the proximal renal tubule and decrease the renal excretion of hydrogen in the distal renal tubule. This table is to explain how to calculate for the appropriate compensation. So when you have a patient present with metabolic acidosis, you want to know if the respiratory alkalosis is appropriate or not. So you will be able to use the Winter's formula by checking the appropriate level of the PCO2, which is equal 1.5 times the bicarb plus 8. And in cases of metabolic alkalosis, you use this formula, PCO2 equal 0.9 times the bicarb plus 16. In cases of respiratory acidosis, for every 10 change in the PCO2, the pH decreases by 0.08 in cases of acute respiratory acidosis, 0.03 in the cases of chronic respiratory acidosis. How would you know if it's acute or chronic? From the history or the clinical vignette in your exam. In cases of respiratory alkalosis, for every 10 change in the PCO2, the pH increases by 0.08 in cases of acute respiratory alkalosis and 0.03 in chronic respiratory alkalosis, and we'll apply that in the clinical cases at the end of this presentation. I would like to emphasize certain facts about the compensation before we start the practice cases. The primary metabolic disorder, the compensation here is respiratory compensation, and the primary respiratory disorder, the compensation is metabolic compensation. So metabolic compensated by respiratory, and respiratory compensated by metabolic. Know that the compensation attempt to normalize the pH but do not return it to normal. Also, the pH never overcompensate. So if the pH change, there is something else but not compensation. So pH or the patient never overcompensate. You need to know that. So compensation attempt to normalize but do not return it to normal. Also, the pH or the patient never overcompensate. Speed of compensation is very important to know. Generally, the lung compensate faster than the kidney. So the changes in the PCO2 is much faster than the changes in the bicarb. For example, if you have a patient with metabolic acidosis, the secondary compensation here should be respiratory alkalosis. So the change in the PCO2, it will take hours. So it's faster to see. But in the cases of bicarb, it changes. Like for example, if you have a patient with respiratory acidosis, the compensation should be secondary metabolic alkalosis or elevation of the bicarb. So this, it takes time. It takes hours to days. So a change in the PCO2 is fast. It changes in the bicarb as a compensation is slow. Case number 1. The ABG here shows pH 7.23 and the PCO2 is 23 and the bicarb is 10. Step number 1, check the pH. The pH is 7.23, which is less than 7.35. This is a case of acidemia. Next step is to check the PCO2 is 23, is less than 40. So this is a case of metabolic acidosis. Both of them, they are deranged in the same direction. And the bicarb here is low. So this will confirm this is a case of metabolic acidosis. You want to know if the compensation of PCO2 to this case of metabolic acidosis is appropriate or not. By using the Winter formula. The Winter formula is the change in the PCO2 equal 1.5 times the bicarb plus 8. So 1.5 times 10 is 15 plus 8 is 23. So 23 here is equal 23 here. So this is appropriate compensation. So again, this is appropriate compensation. So this is a case of metabolic acidosis with secondary respiratory alkalosis. So again, the pH here is low and the PCO2 is low. This is metabolic acidosis, and the bicarb is low. This will confirm. You want to know if the compensation is appropriate or not. So by using the Winter formula, the result here is the same as the PCO2 or very close. So this is appropriate compensation, metabolic acidosis with secondary respiratory alkalosis. Another hint also, you can match this number with the two number after the decimal of the pH. So 23, 23, or if they are very close, this means appropriate compensation. This is just a shortcut if you do not remember this formula or you are in hurry. Another clinical case scenario. The pH here shows 7.50 and the PCO2 is 46 and the bicarb is 34. Step number 1, check the pH. The pH is 7.50 is more than 7.45, so this is a case of alkalemia. Next step is to check the PCO2. The PCO2 is more than 40, 46, so both of them are elevated in the same direction. This is a case of metabolic alkalosis. You want to know if the respiratory acidosis here appropriate compensation for this metabolic alkalosis or not. So by using this formula, which is a change in the PCO2 equal 0.9 times the bicarb plus 16. So 0.9 times the 34, which is the bicarb plus 16, will be equal 46. So 46 here equal the 46 here. So this is appropriate respiratory acidosis compensation. So this is a classic presentation of metabolic alkalosis with secondary respiratory acidosis. So again, quickly, the pH is elevated, the PCO2 is elevated. This is metabolic alkalosis, and the bicarb here is elevated, will confirm the diagnosis. And the PCO2 is elevated as a secondary respiratory acidosis compensation. You want to know if this compensation is appropriate, you use this formula and the result is 46, the same. So also you do use the shortcut, which is 46 here, after the decimal is 50, so they are very close. So this respiratory acidosis is appropriate compensation for this metabolic alkalosis. So this is a case of metabolic alkalosis with secondary respiratory acidosis, which is appropriate compensation. Case number 3. This is a 15 years old girl found unresponsive with a bottle of alcohol beside her. Her ABG showed pH is 7.16. and the PCO2 is 60 and the bicarb is 18. Step number 1, check the pH. The pH is 7.16, is low. This is a case of acidemia. Step number 2, check the PCO2. The PCO2 is 60, which is more than 40. So this is a case of respiratory acidosis. The next step is to check if the bicarb here is appropriate compensation for this respiratory acidosis or not. So this patient should have metabolic alkalosis instead of acidosis. So this is inappropriate. To confirm that, you can use this formula. For every 10 change in the PCO2, the pH should decrease by 0.08. Why I used 0.08 instead of 0.03? Because this is acute. In acute, you use 0.08, not 0.03. 0.03 in the cases of the chronic. So if you calculate that, you have 20 above the 40. So it's 210. So you multiply 0.08 times 2 is 0.16. So the drop in the pH here is much more than 0.16. So if you do the average pH is 7.4 minus 7.16 is 0.24, which is much more than expected. So this patient is having a separate metabolic acidosis beside the respiratory acidosis. So the diagnosis here, respiratory acidosis with independent or separate metabolic acidosis. So again, the pH here is low and the PCO2 is high. This is a case of respiratory acidosis, but the bicarb compensation here is not appropriate. So here is acidotic instead of being alkalitic. So this patient is having independent metabolic acidosis. So respiratory acidosis with separate metabolic acidosis as well. And this is expected in this case. Why? Because this patient is drinking a lot of alcohol, causing severe metabolic acidosis, and maybe respiratory depression. The patient was unconscious and unresponsive, so retaining a lot of CO2. So this is a case of respiratory acidosis with separate metabolic acidosis. So the compensation here is inappropriate. Case number 4. The ABG here shows pH 7.13, the PCO2 is 32, and the bicarb is 9. Check the pH. The pH is low, is 7.13, less than 7.35 is acidemia. And the PCO2 is low. This is a case of metabolic acidosis. Both of them are deranged in the same direction. Both of them are low. This is a metabolic acidosis. The next step, you want to check if the compensation of respiratory alkalosis is appropriate for this metabolic acidosis or not. So you can use the shortcut by looking at the actual number of the PCO2 32 and the 2 number after the decimal of the pH. So here is much higher than the 13, is almost more than double. So it's more than double. So this is inappropriate compensation. So it is higher. So this is a separate respiratory acidosis. To confirm that, you can use the Winter's formula. The Winter's formula is PCO2, to remind you again, equal the 1.5 times the bicarb plus 8. So 1.5 times 9, which is the bicarb plus 8, is 21.5. So the appropriate compensation of respiratory alkalosis should be 21.5. There is a big difference here. This is 32, so it's much higher. You can add 2 plus or minus to just to make it close, but it's still very far. So the 32 is much higher. So this patient is having a separate respiratory acidosis. So again, in this case, the pH is low and the PCO2 is low. This is a metabolic case, and the bicarb is low. This is metabolic acidosis. And you want to know if the compensation is appropriate or not. You look at the 32 and compare it to the number, 2 numbers after the decimal. This one is much more than 13, which is more than double. So this is inappropriate respiratory alkalosis. So even it's still less than 40, but this is not appropriate, it's much more. And to confirm also by using the Winter's formula in the previous slide shows 21.5. So still it is a big difference. So this patient is having a separate or independent respiratory acidosis. So finally, this case is metabolic acidosis, and the second disorder or independent disorder is respiratory acidosis. How to calculate the Non-Anion gap? It is critical and very important to know how to do that. This can make a difference in the differential diagnosis and the management as well. The Non-Anion gap is the sodium minus chloride plus bicarb. Sodium minus chloride plus bicarb. The normal Non-Anion gap is 12 plus or minus 2. 12 plus or minus 2. So again, sodium minus chloride plus bicarb, and the normal value is 12 plus or minus 2. It is very important to know how to calculate the delta ratio. When do we need to calculate the delta ratio or to know about the delta ratio? If the Non-Anion gap is elevated. So cases of elevated Non-Anion gap, you need to calculate the delta ratio. Why? To determine if mixed acid-base disorder is present. For example, metabolic acidosis with concurrent metabolic alkalosis. So metabolic acidosis with metabolic alkalosis, or to find out if the cause is lactic acidosis. So calculating the delta ratio will be very helpful in these cases. Delta ratio equal measured Non-Anion gap minus normal Non-Anion gap. So you have to measure it, then you minus the normal Non-Anion gap. Normal Non-Anion gap is 12, and the normal bicarb, which is 24, minus the measured bicarb. So again, measured Non-Anion gap minus 12 and 24 minus the measured bicarb. So again, the benefit of calculating the delta ratio is to find out if there is any simultaneous presence of acid-base disorder in the blood gas or mixed disorder. If the ratio between 1 and 2, this indicate pure elevated Non-Anion gap acidosis or lactic acidosis. The average value of lactic acidosis is 1.6. DKA, usually the delta ratio will be close to 1 because of loss of ketone in the urine. If it is less than 1, this indicate high Non-Anion gap and normal Non-Anion gap acidosis. If more than 2, this indicate high Non-Anion gap acidosis and concurrent metabolic alkalosis or pre-existing compensated chronic respiratory acidosis. It is very important to learn how to calculate the osmotic gap. The osmotic gap is beneficial in the cases with suspected alcohol ingestion when they present with metabolic acidosis. serum osmolality minus the calculated serum osmolality. This will be equal the osmotic gap. The calculated serum osmolality is 2 times the sodium plus glucose divided by 18 plus BUN divided by 2.8. You need to memorize it. Normal osmotic gap should be 12 plus or minus 2. The causes of elevated osmotic gap, especially if it's more than 20, will be expected in intoxicated patients. For example, ethylene glycol like antifreeze, alcohol, or methanol. Clinical case scenario. This is a 17 years old boy found in the garage, brought by the ambulance to the ED with altered mental status. The ABG shows pH is 6.9 and the PCO2 is 20 and the bicarb is 4 and the carbon monoxide was less than 1. The electrolyte is sodium 153, the potassium is 4.1, BUN is 15.5, the chloride 109, glucose is 94, and the serum osmolality is 335. So step number 1 in any EBG you check the pH. The pH is 6.9 is less than 7.35. This is a case of acidemia. Step number 2 to check the PCO2. The PCO2 is 20 is less than 40. This is a case of metabolic acidosis. Also the bicarb is low, here is 4. So the step 3 to check for compensation, if the compensation is appropriate or not. So you will do that by using the Winter formula. 1.5 times 4, which is the bicarb, plus 8 will be equal 14. So the actual value of the PCO2 here is 20. So this is inappropriate compensation. So this patient is having respiratory acidosis or slight respiratory acidosis, and this is expected because the consciousness is altered. So his mental status is altered, and the patients will not be able to hyperventilate as appropriate as if the patient is awake. Next step, you want to know the anion gap. The anion gap here is 153, or the sodium minus the chloride plus the carb. So the sodium here is 153 and the chloride is 109. So this is 109 plus 4, which is the bicarb. So this equal 40. This is very high anion gap. The normal anion gap, to remind you, is 12. So this is 40. This is elevated anion gap. So this is metabolic acidosis with elevated anion gap. In this case, we should suspect that this patient may ingested or intoxicated with alcohol. So the next step is to do the delta ratio to find out if there is any mixed disorder with it or not, to confirm your diagnosis. So the delta ratio here is the measured anion gap minus the normal anion gap. The measured anion gap here is 40 minus 12, which is the normal anion gap you know in your mind, and 24, which is the normal bicarb minus the measured bicarb. The measured bicarb here is 4. So 40 minus 12 is 28. 24 minus 4 is 20. If you divide these, is 1.4. So this is here fall under the category of delta ratio between 1 and 2. So this ratio here is 1.4. This is a pure elevated anion gap acidosis. So there is no expected mixed acid-base disorder with this type of blood gas or this type of presentation. So this patient was found in the garage with altered mental status, and his blood gas and electrolyte shows metabolic acidosis with high anion gap. The next step is to check the osmolar gap to confirm the suspicion or the diagnosis of ingested ethanol or similar substance. So you start calculating the osmolar gap by calculating the osmolality first. So the calculated osmolarity is 2 times the sodium plus glucose divided by 18 plus BUN divided by 2.8. So the sodium times 2, 153 times 2 is 306, and 94 divided by 18 is 5.2, and 15.4 divided by 2.8 is 5.5. So the total is 317. So the serum or the measured serum osmolality in your lab is 335, and your calculation or the calculated serum osmolality is 317. So 335 minus 317 is 18. So this is elevated osmolar gap. So this patient is having metabolic acidosis, high anion gap, and a high osmolar gap suggests ethanol intoxication. Urine anion gap. How to calculate the urine anion gap? By calculating the sodium, of course, in the urine. Sodium plus potassium minus chloride in the urine. Sodium plus potassium minus chloride in the urine. The normal value should be in negative. If it comes positive, this suggests renal tubular acidosis. In cases of metabolic acidosis, especially if the anion gap is not elevated, check the urine pH. If the urine pH is more than 6, this is suggest renal tubular acidosis. So renal tubular acidosis can be also suspected in the cases when the urine pH is elevated, in the cases of metabolic acidosis with normal anion gap. Also, you can suspect that when you check the urine anion gap by calculating the sodium and potassium and chloride in the urine. Sodium plus potassium minus chloride. If the value comes negative, this is normal. If it comes positive, this suggests renal tubular acidosis. Metabolic acidosis. The mechanism of metabolic acidosis is excess acid production. For example, in cases of DKA, increased acid intake, like for example acetyl salicylic acid intoxication, decreased renal acid excretion, increased bicarb loss in GI tract, like in cases of diarrhea, or excess bicarb excretion in the kidney. Metabolic acidosis with normal anion gap is very important to know that. The cause of or the mechanism of metabolic acidosis with normal anion gap is excessive loss of bicarb, either in the stool, like in cases of diarrhea, or in the urine, like the cases of renal tubular acidosis, or by inability to excrete hydrogen ions. Causes of normal anion gap metabolic acidosis. For example, diarrhea. This is very common and important to know. Anastomosis of ureter with the GI tract, renal tubular acidosis. In this case, the urine pH will be more than 6 in most of the cases. Medication, for example, acetazolamide, and excessive resuscitation or excessive fluid, IV fluid intake with sodium chloride. This is a real case, very interesting, presented to me before. This is a 3-year-old boy with severe developmental delay, brought to the clinic by his mother for referral to physical therapy. The child is not able to walk, had eye surgery 1 year before this visit for cataract, and he is able to say only few words. In physical examination, the child has a broadened wrist, busting of the forehead, nystagmus, poor muscle tone, and poor reflexes. Laboratory evaluation showed sodium, normal sodium, normal potassium, chloride is slightly elevated, the bicarb is 17, is low, the BUN is 12, creatinine is 0.4, glucose is 95, normal calcium, but the phosphorus is very low, is 2.3, and the alkaline phosphatase is very elevated, is 1250, and the CK is normal, and the urine phosphorus and the calcium, they were elevated. MRI was done for this patient, and it was positive for white matter abnormalities in the periventricular area. So what is the most likely diagnosis in this case? So in this case, the red flags in this case is a child with severe developmental delay, is not able to walk, has cataract, saying only few words. In physical examination, has nystagmus, poor muscle tone, which is neurological disorder. The laboratory test here showed the sodium 135, the chloride is 110, and the bicarb is 17. So there is a metabolic acidosis. By calculating the anion gap, he has normal anion gap metabolic acidosis. And also he has hypophosphatemia and elevated alkaline phosphatase. And also in the MRI shows white matter abnormalities in the periventricular area. So by pointing out these red flags, you should now suspect what is the most likely diagnosis. The final diagnosis of this case was oculocerebrorenal dystrophy, or Lewis syndrome, which is renal tubular acidosis, and we're able to know that from the calculation of the anion gap. The anion gap was normal anion gap with metabolic acidosis. Hypophosphatemic ricket, the alkaline phosphatase was very high, and the phosphate was low, or hypophosphatemia with normal calcium. High urine phosphorus and calcium, cataract, neurological disorder, and the positive finding in the MRI. The treatment of this case of the hypophosphatemic ricket in this case is vitamin D, oral phosphorus, bicarb to keep the plasma bicarb more than 22. Causes of elevated anion gap metabolic acidosis. Ketoacidosis, for example, is starvation or fasting. Diabetic ketoacidosis. Lactic acidosis also can cause that because of tissue hypoxia or excessive muscular activity, or cases of inborn errors of metabolism. Ingestion also can cause elevated anion gap metabolic acidosis. For example, ingestion of methanol, ethylene glycol, salicylic acid. Renal failure also can cause elevated anion gap metabolic acidosis. DKA or diabetic ketoacidosis is a very important cause of acidemia. Presents with hyperglycemia, high anion gap acidosis, ketonuria, and ketonemia, and the body will compensate for this acidosis by hyperventilation, deep respiration, and will cause respiratory alkalosis for this metabolic acidosis. So these patients usually expected to have metabolic acidosis with secondary respiratory alkalosis. Classification of DKA by the severity of the acidosis. In mild cases, the pH will be 7.21 to 7.30, the bicarb between 11 and 15. In moderate cases, the pH is lower, is 7.11 to 7.20, and the bicarb is much lower, is 6 to 10. In severe cases, the pH is less than 7.1 and the bicarb is less than 5. This is severe. Lactic acidosis is a very important cause of metabolic acidosis with elevated anion gap because of the shift to anaerobic pathway for energy production as a result of tissue hypoxia, and this can be due to inappropriate tissue perfusion, like in cases of shock, inappropriate oxygen supply, or mitochondrial dysfunction, like genetic cases. Inborn error of metabolism also is a very important cause of metabolic acidosis. It causes high anion gap metabolic acidosis. The example of that, urea cycle defects and organic acidemia. They present with ketoacidosis, lactic acidosis, poor feeding, failure to thrive, seizures, vomiting, and even coma or death. Consequences of metabolic acidosis can cause or can be associated with cerebral edema, decreased cardiac contractility, arrhythmia, impaired vasomotor tone, pulmonary vasoconstriction, hyperventilation, insulin resistance, and hyperkalemia. General management of cases of severe metabolic acidosis, of course, correction of the underlying cause. For example, in cases of sepsis, providing antibiotics, oxygenation, ventilation, tissue perfusion with restoring the intravascular volume by giving IV fluid. Sodium bicarb is controversial to use for correction of severe metabolic acidosis. This can be actually make it worse. And American Heart Association had few exceptions for using the sodium bicarb in cases of cardiac arrest if the patient not responding to oxygenation, ventilation, IV fluid, chest compressions, epinephrine in the recommended doses. But generally, restoring the intravascular volume, oxygenation, ventilation should be enough for most of the cases of severe metabolic acidosis. Using bicarb is controversial. You have to be careful when you use it. It may give you false improvement, but in reality the patient may have or worse acidosis, or it may worsen the acidosis. Classification of metabolic alkalosis. The causes of metabolic alkalosis classified according to the chloride. If it's chloride responsive, which is by checking the urine chloride, if it's less than 15. If the urine chloride less than 15, this is chloride responsive, and the most common cause is vomiting, pyloric stenosis, diuretic, cystic fibrosis, or chloride losing diarrhea. If you have a patient presents with chloride resistance type metabolic alkalosis, by checking the urine, if the urine more than 20, you check the blood pressure. If the blood pressure is high, the most common cause of that is adrenal tumors and renovascular diseases. If the blood pressure is normal, most common cause of this metabolic alkalosis is Bartter syndrome and Gitelman syndrome. Clinical presentation of metabolic alkalosis is hypovolemia. This patient usually very dehydrated, hypokalemia, and this can cause muscle weakness, arrhythmia, paresthesia, and numbness. Causes of respiratory acidosis. Anything can increase the PCO2 in the lung or cause retention of PCO2 can cause respiratory acidosis. For example, upper airway disorders, lung diseases, respiratory muscle weakness, CNS depression, for example, intoxication, neuromuscular disorders. Causes of respiratory alkalosis, which is decrease of PCO2 in the lung less than 40, is carbon monoxide poisoning, cyanotic heart diseases, mechanical ventilation, and hyperammonemia. We'll end this presentation with few clinical case scenarios. This is a 16-year-old girl, previously healthy, presents to the ER with a 4-day history of nausea, vomiting, fever, chills, diarrhea, leg cramps, abdominal pain, and headaches. She is finishing her menstrual period and arrives with a tampon in place she inserted yesterday. Vital signs: the heart rate is elevated, is 165, respiratory rate is 28, is elevated for her age, and the blood pressure is 65/30 is low. and the oxygen saturation is 100% but in 4 liters of oxygen. The most likely diagnosis in this case, because of the history of tampon insertion and the shock presentation, is toxic shock syndrome, which is later was confirmed with positive antibody testing. The result of the first blood gas done for this girl is the pH is 7.24 and the oxygen is 138, the PCO2 is 19 and the bicarb is 8. How to understand this ABG? So step 1, check the pH in the blood gas is here is 7.24 is acidemia. Check the PCO2 is 19 is low, so both of them are low. This is metabolic acidosis. This is metabolic acidosis, and the PCO2 here is low, which is respiratory alkalosis. So this is a case of metabolic acidosis with secondary respiratory alkalosis. So the next step in this patient, you want to calculate the anion gap. So the sodium here is 133, the potassium is 4.2, the chloride is 109, the bicarb is 12, and the anion gap is 12 as well. This is the measured one. And the blood urea nitrogen is 49, the creatinine is 3.96, which is elevated. This is a renal failure. Calcium is 5.2, but you need to correct because of the low albumin. The albumin here is 2, so the albumin is very low. So when you have a presentation like that, you need to correct the anion gap for this low albumin. So how to calculate the anion gap? Again, sodium minus chloride plus bicarb. So the sodium here is 133, the chloride is 109 plus the bicarb, which is 12. So 133 minus 21 equal 12. So which is match the measured one. So here you want to correct this anion gap because of the low albumin. So for each 1 gram drop in the serum albumin, you need to increase the anion gap by 2.5. So this patient has 2, so 4 minus 2 equal 2, so 2 times 2.5 equal 5. So 5 plus 12 is 17. So this patient is having metabolic acidosis with high anion gap. So this patient, despite the oxygen the patient is receiving and the IV fluid, keep getting worse. The second EBG was ordered and shows pH 7.06. The oxygen level is 63 in the ABG, despite the 4 liters the patient is receiving, and the PCO2 is 47, and the bicarb is 13.2, and the serum lactate here is elevated is 6.9, and expected in this case of severe shock. The explanation of the second ABG, the pH is 7.06, this is severe acidemia, and the PCO2 is 47, is inappropriate for this type of acidosis. How to confirm that? By calculation here of the or using the Winter's formula. The PCO2 or the change in the PCO2 1.5 times the bicarb plus 8, so 1.5 times 13.2 here plus 8 is 27. So the PCO2 should be here 27.8 or around this number, but here is almost double. So this is inappropriate compensation. So what is the so this is a second disorder, which is respiratory acidosis. So this patient is having metabolic acidosis without respiratory compensation due to developing respiratory failure. This is a 12 years old boy who is moderately dehydrated, admitted with a 2-day history of acute severe diarrhea. The electrolyte of this patient, sodium is 134, potassium 2.9, chloride 108, bicarb is 16, BUN is 31, and creatinine is 1.5. The ABG of this patient, the pH is 7.31, PCO2 is 33, bicarb is 16, and the oxygen is 93. What is the acid-base disorder of this patient? So this is a patient with a moderate dehydration and severe diarrhea. What is the possibility of this blood gas? It could be normal anion gap acidosis because of the diarrhea, or elevated anion gap because of associated lactic acidosis because of hypovolemia and poor tissue perfusion. So either normal anion gap or elevated anion gap. So you can have two possibilities in the cases of diarrhea: normal anion gap or elevated anion gap. Why is elevated? Because of hypovolemia and poor perfusion and secondary lactic acidosis. You want to understand the acid-base disorder of this patient. Step number 1, check the pH. The pH is 7.31, is low, is less than 7.35. This is a case of acidemia. Check the PCO2. The PCO2 is low, so both of them, they are low in the same direction. This is a case of metabolic acidosis. Step number 3, you want to know the compensation. Is it appropriate or inappropriate? So this patient compensating by respiratory alkalosis. So check the PCO2 here is 33, and the on the last two number on the decimal is 31, so it is very close. So this is appropriate compensation. So there is no separate respiratory disorder in this case. So this patient is having metabolic acidosis with secondary respiratory alkalosis. You can confirm this number by checking the Winter's formula. Winter's formula, you do 1.5 times the bicarb, which is 16 plus 8, so it's 32. So 32 here is very close to 33 of the actual number of the patient. So this is appropriate compensation. So this patient is having metabolic acidosis with secondary respiratory alkalosis. Step number 3, you want to calculate the anion gap. You want to know if this is normal anion gap metabolic acidosis or high anion gap metabolic acidosis. The anion gap here, how to calculate the sodium minus the chloride plus the bicarb. The sodium is 134 and the chloride is 108 plus 16, so equal 10. This is a normal anion gap. So the final diagnosis in this patient, normal anion gap acidosis with adequate compensation, most likely secondary to severe diarrhea. Most likely secondary to severe diarrhea. This is a very extremely common presentation in pediatric, so know it by heart. I will end my presentation with this nice case. This is a 16 years old female with type 1 diabetes, presents to the emergency department with 1-day history of nausea, vomiting, polyuria, polydipsia, and vague abdominal pain. Physical examination noted for deep sighing breathing or audible breathing, orthostatic hypotension, and dry mucous membrane. Labs, sodium is 132, potassium 6, chloride 93, bicarb is 11. Glucose is 720, BUN is 38, and creatinine is 2.6. UA, the pH is 5, specific gravity is 1010, ketone is negative, glucose is positive, and the plasma showed trace of ketones. ABG, the pH is 7.27, the bicarb is 10, and the PCO2 is 23. What is the acid-base disorder of this case? This is a classic presentation of diabetic ketoacidosis. The possible acid-base disorder finding in this case can be elevated anion gap acidosis because of diabetic ketoacidosis, or elevated anion gap because of lactic acidosis. Why lactic acidosis? Because of hypopholemia and poor tissue perfusion. And also this patient can present also with metabolic alkalosis secondary to the vomiting. When the patients vomit, they lose acid from the stomach, and this can cause concurrent metabolic alkalosis. And in this case, the delta ratio will help to identify if this is associated or not. Let's analyze the ABG. The ABG here, the pH is 7.27, the bicarb is 10, PCO2 is 23. Step number 1, check the pH. The pH is 7.27, which is less than 7.35. This is acidemia. Step number 2, check the PCO2, then the bicarb. The PCO2 is 23, so this is a case of metabolic acidosis. Why? Both pH and PCO2 they are low in the same direction, so this is a case of metabolic acidosis. Also confirm with the bicarb. The bicarb here is less than normal, is 10, so this is a case of metabolic acidosis. Step number 3, check the compensation. How to check the compensation? By two ways. Shortcut, to look at the 20 here, the PCO2 is 23, and the last two number of the after the decimal is 27. So here if it's minus or plus 2, so this will be around 25, and this 27, they are very close, so this is appropriate compensation. Confirm that with using the Winter's formula. 1.5 times the bicarb plus 8, 1.5 times 10 plus 8 is equal 23. So here match the actual value of the PCO2 on this ABG. So this is appropriate compensation. So the diagnosis here is metabolic acidosis with secondary respiratory alkalosis. So this patient is having metabolic acidosis. The next step is to calculate the anion gap. The anion gap here is sodium minus chloride plus the bicarb. 132 is the sodium, 93 is the chloride, and the bicarb is 11. So the result is 28. So this is elevated anion gap. So this is a metabolic acidosis with elevated anion gap. Next step is to check the delta ratio. to rule out any concurrent metabolic alkalosis because of the vomiting. So the anion gap, you need to calculate first the anion gap, the measured one, which is 28, minus the normal anion gap, minus 12. This equals 16. Then the normal bicarb minus the measured bicarb. Normal bicarb is 24 minus 11, so equal 13. So 16 divided by 13 will give you the ratio. So the ratio is 1.2. So you know from the previous slide when we spoke about the delta ratio, that the delta ratio between 1 and 2, this indicate pure metabolic acidosis. So there is no concurrent metabolic alkalosis in this case. So finally, the final assessment of this case is compensated elevated anion gap acidosis, most likely secondary to diabetic ketoacidosis. Thank you so much for listening. This lecture is only for educational purpose and is not intended to direct care of any specific patient. Please consult your physician and the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of experienced and licensed healthcare professional. Thank you again.